further ado, Carissa is one of the students funded by the Doris Duke program, and she is mentored by all the work we've heard from, and also working with a group at the University of North Carolina in China. So, Carissa.
So yeah, I think I know pretty much everyone here, but for those of you who don't know me, Carissa, just finished my third year of med school, and I'm going to China. And I feel like it's probably good to give a little bit of background on why I decided to go to China before I go into my project. So in the past few years of med school, I've kind of fallen into this role of, really strong interest in working with Chinese-speaking populations. I worked at Chinese hospital between my first and second years, and then for third year happened to be at the general for 5 out of my 6 rotations. And just sort of fell into this role of interpreting for Cantonese-speaking patients and working. If there was a Cantonese patient on my team, I would sort of step out and want to try to work with that patient. And I just felt like there was a big gap, a big knowledge gap, and not just language, but also cultural and sort of understanding different health systems. Even within San Francisco, understanding how NEMS works, how Chinese hospital works, and their standards of care is very different from sort of the standards that UCSF holds ourselves to, whatever that may be. I definitely sensed this sort of tension. I thought, what better way to understand this population and this health system than to go back to China and figure it out myself. And of course, learn more of the language as well. So I'm leaving this paper. So my project title is Detention of Hep C positive intravenous drug users in methadone treatment in Guangdong province, China. And so I'm going to be doing a lot of sort of setting the stage and framing the problem. So China has the largest Hep C positive population in the world. 42 million people in China are Hep C positive, compared to about 5 million here. Almost all new HCV infections now are transmitted by IV drug use. So in the past, like maybe in the 60s or so, there was some transfusion-related, transmissions of Hep C, but now it's all through IV drug use. And there is some, sexual transmission as well, but it's not as efficient as it is through intravenous drug use. And here is Guangdong here, really small. And I'm going to be going, I'm going to be going here to Guangzhou, and here's Hong Kong. So that's sort of the area that I'm going to be in, sort of Southeast Asia, or Southeast China. And if Hong Kong is kind of like New York City, Guangzhou is kind of like, I don't know, like San Jose or Fresno or something. So, it'll be interesting. I've heard things. So 2/3 of IV drug users in China are Hep C positive. And in the area that I'm going to be going to, it's actually much more concentrated. So up to 90% in some inland provinces, which is really high. In Guangdong, based on the data from the methadone clinics that they have there, it's about 78%, which is actually comparable to here. So here, it's like 72% of IV drug users are Hep C positive. And I wasn't sure if all the pups were going to be here, but I was going to set a little bit of background on what Hep C infection is. How many of you guys have taken care of patients who happen to have hepatitis C? Almost like everyone, right? So there's a healthy liver on the left. And a liver is responsible for a lot of things. There's toxins in the body, synthesizing coagulation products. It's really important for your body, basically. And on your right is a cirrhotic liver, and actually this is a liver with hepatocellular carcinoma. So obviously it looks a lot less healthy. And this is something that Hep C, is part of the pathogenesis of liver. So it's a bloodborne illness, so it's transmitted by blood. Very, very infectious. So the efficiency of transmission of Hep C with intravenous drug use is much higher than HIV, actually. So if you're a chronic IV drug user, your chances of being Hep C positive are over time, close to 100%. Of those infected, 80% will become chronically infected, and 20%, for reasons not too clear, are able to clear the infection. And there's certain sort of things that modify your risk. So concurrent alcohol use, HIV co-infection increases your risk of also, continuing to be chronically infected. And this puts you at increased risk for cancer and stage liver disease and ultimately death. So the WHO put out this statement, testing, treatment, and prevention programs must be expanded to curtail the morbidity, mortality, and economic costs associated with HCV infection. Which brings us to methadone. I'm going to be working in methadone clinics. So do you guys all know what methadone is? Yeah. Okay. So it's an oral substitution therapy. So methadone is a long-acting drug that acts on the same receptors as heroin and other opiates. And it produces, it cuts off the withdrawal effect without producing the symptoms of euphoria. And it's oral, which is key, because when somebody is in methadone treatment, the idea is they stop injecting. And so they're taking what is still a controlled substance, but it's a harm reduction strategy. So China recognized, we have this huge problem, HIV, HCV, we gotta solve it. And so since 2004, they've set up 700 methadone clinics in the country, which is incredible. And within Guangdong, there's 49. And the program has served since that time 300,000 IV drug users. And it's a centralized system, so as far as I know, the data that's collected is centralized and stored in one place, so demographic data about all the clinics, which is a really rich source for us to learn more about the behaviors and sort of the demographics of this population over time. And then also methadone has been now a way to access what is previously a very marginalized population, if you think about it. IV drug users, there's a lot of stigma associated with, there's a lot of comorbid mental health issues, housing. Your image of an IV drug user is like, somebody in a slum somewhere. So these are people who don't normally have the same kinds of access to healthcare as the rest of the population. So what methadone has done is it's provided an opportunity for people to get tested for HIV, for HCV, and in China, be referred for treatment for HIV, because China has also made it a national priority to test and treat HIV for free. The same has not happened for Hep C. So it's sort of now this proxy of the health system where you can reach this previously sort of marginalized population.
So how good actually is the information that's available about the healthcare system? When I think about, for instance, my virus, which is HPV, the information that's publicly available and what people were telling us privately, quite different. And so all the fantastic information that you're giving, is that real? Is it coming from government sources? Is there any disconnect with reality on the ground?
Oh, that's where I'm going. We'll see. I mean, I think there have been published things, and then as Ruby pointed out really astutely, the published data on methadone clinic is from government officials. And, currently for IV drug users, it's sort of like this fork in the road. Either you get lucky and you get referred to methadone treatment, or you get unlucky and get placed in detention or work camps. And that's been how China has dealt with the problem in the past, and realized from a public health perspective, it's not helping us curtail our HIV, HCV infection rates. But actually on the ground for a user, how effective is this? How much access do they really have? Those are all really important questions that I'm still reading the literature to figure out. Yeah, here. And another big problem is dropout rates. So 36% of clients are out of care at 3 months. And there are a lot of different reasons for this. A migrant health population is a big reason. A lot of people relapse, and a lot of people are caught for whatever reason and incarcerated. So it's not perfect. So here's sort of the golden triangle. So prevention, testing, and treatment. And methadone stops IV drug use, and so that's a way of prevention. And now methadone is now a place for testing as well. But reduce your incidence of hepatitis C, but in order to really reduce your prevalence, you need to treat people you've diagnosed. So the standard of care for HCV treatment now is, so of all the Hep C positive patients you guys have taken care of, how many of them, have you come across anyone who's been treated? Yeah. Would you say most of your patients have been treated, or some of them? Yeah, let's see what So HCV treatment, I had to look it up because it's not something I feel people are very comfortable with, and there's not a lot of knowledge about Hep C treatment. So it's once daily injection and then daily oral ribavirin. And not everyone has 100% response. So depending on what genotype of Hep C you have, genotype 1, which is the worst one, with this current regimen, it's about a 60 to 70%. We call it SVR, sustained virological response, which is undetectable levels of virus in the body with treatment. And then genotypes 2 and 3 have much better response to treatment. And people cite different reasons for not referring people for Hep C treatment. There's variable reimbursement rates, high costs for treatment, and so on. So it's faced more barriers than HIV, for example, where early advocacy really brought down the cost of treatment. And also these medications are still, they come out with new versions, and so they're not available generically. And there's strong evidence to support Hep C treatment in people who are active IV drug users as well. However, most often in China, abstinence is required for referral to treatment. And this, as far as my knowledge, is not evidence-based. And now, in the US, there's some really exciting research done on these new direct-acting agents, DAAs. So they specifically target parts of the HCV life cycle. And so people are saying this is going to be an oral medication, it's going to cure Hep C forever. Everyone's going to have a response, even genotype 1. And there's studies are showing like 90, over 90% response in some patients. But there's problems, obviously. So the target patient population, they're IV drug users. This is a marginalized population, high dropout rates, no history of advocacy for treatments, and they have lack of knowledge about hepatitis C, let alone the appropriate treatments. HCV treatment is effective, but it's not accessible. The cost is anywhere here from $10,000 to $20,000 per patient, is what I've heard. And with new treatments on the horizon, I think that's really great for a certain number of people with Hep C, but for the population you're really trying to target, which is people who are IV drug users, I feel like there's a really big gap there. So, anyways, this leads me to my research question. And this is sort of my running assumption or my hypothesis, which is methadone clinics are a proxy for the healthcare system and serve as the opportunity to deliver care and advocate for greater access to treatment. So my research question is this, and it's very specific. So what are the correlates of retention and methadone treatment of Hep C positive IV drug users in Guangdong province, China? The goal being to characterize this target population, to better inform counseling and education strategies, and then finally to advocate for increased access to Hep C treatment. And then my study design, so we've been going over this a lot in our TCR classes. So this is going to be a retrospective cohort study. Data that's already been collected on these patients, because like I said before, centralized system, lots of great data. And my first hypothesis is to investigate individual level correlates of retention of Hep C positive IV drug users in these clinics. So HIV literature suggests that age, gender, history of incarceration, these are very important factors for predicting whether someone will stay in methadone treatment or not. And so that's my hypothesis. And that's my approach, which is basically I'm checking to see who drops out at 4 weeks, 12 weeks, 24 weeks, and then comparing between those two groups. Is there a are these actual predicting factors? And then
So the two groups are HCV positive and HCV negative?
no, so they've all had a new diagnosis of HCV, so that's time 0. Okay, and then, so I guess the outcome is dropout. And then the variable is age or gender or history of incarceration. So,
In formulating that specific aim, are you thinking also that those correlates will be different between an HCV positive and an HCV negative group?
well, you mean, does HCV infection alone have an impact on retention?
But you're not following HCV negative.
Right. But I'm just wondering.
As a question?
Yeah.
Yeah. I mean, another interesting thing is HIV co-infection as well, and whether HIV co-infection modifies somebody's risk for, for whatever reason, dropping out of care as well.
For example, HIV may have more social support or
Mhm.
programmatic support that allows them to stay.
Or on the flip side, they're managing another chronic illness, and therefore this falls off entirely.
Or they may have drug interactions that may.
Exactly. Yeah, that's actually cited a lot in the literature about sort of hepatotoxicity of some of these medications. So my aim too is pretty much the same question, but to look at clinic level correlates. So the ratio of healthcare providers to clients and whether that predicts dropout as well. So sort of a straightforward study design for a very complex social issue. And I'm going to be doing multi-level analysis to try to control for certain confounders. And then I'm also interested in doing a survival curve to look at, if we can calculate hazard ratio for, if we are able to show significance for a predictor, what that predictor tells us about the risk for loss of retention. So a lot of study limitations. It is a retrospective cohort study, so we're not controlling for a lot of things. And then the big question for me now is, how translatable is this to action or to advocacy? And right now I'm working on a systematic lit review. I might be also doing some qualitative stuff when I'm out there with my mentor. The question really is, if the problem really is HCV treatment access, does understanding retention allow us to move more in the direction of greater access, or is it its own self-question?
Chris, I'm just wondering overall, in terms of your future directions, it will probably depend a lot on political will. Do you have any sense of how the politics locally and then nationally are going and how they would be supportive of? Do they care if people stay in or not? Are they going to put resources into having people come back? Because Guangdong politics is probably not going to be the same as San Francisco politics.
Yeah, and I mean, it's actually great that I was paired with Ruby, because Ruby knows something about Chinese politics and Chinese law, which is, probably going to be one potential lit review project that she was going to work on. It is a very, very, very different environment. And, for me as an American coming in, there are certain things to be very careful about. We don't want to cause big ripples. And I think the fact that, China has recognized that this is a problem and that they've set up this methadone clinic system pretty much overnight. I mean, if you really think about the history of methadone in China versus the history of methadone here, it's been very different. But it's still I think it's still very much evolving. And they've put a lot of political will behind HIV because I think it's a lot, in terms of funding dollars, in terms of research, there's a lot more to work with in that arena. Whereas Hep C is very much a silent epidemic in terms of, who it affects. It's a chronic illness. You don't see it. A lot of people who are sick with it don't feel like they're really sick with. The morbidity and mortality, the DALYs that we learned about, are really quite significant. And it carries over too. Here in the Bay Area, you see a lot of immigrants with Hep C infection, Hep B infection.
Just a little bit more of the data instruments. How are the data being collected?
Oh, okay. So the data is currently in China. Which is why I have to go there.
It's de-identified.
It's de-identified, so we didn't have to get CHR approval, although we tried, but they wouldn't let us. So it's de-identified, and it's basically just a ton of demographic information. So age, where they're from, and then an appointment log, and then all of their comorbidities. So like whether they're positive, MC positive.
So these are data that are entered to standard questionnaire.
So in the intake process for a new client, that's where a lot of data is gathered. And then over time, just sort of progress
And
notes.
they use the same one across these 45 clinics.
As far as, so the ones that are run by the Guangdong CDC, yes. So for the scope of my research, it is standardized. I don't know about the rest of China.
What kind of database is it?
I actually don't know.
Yeah.
Yeah. Might be an Excel. Krista, you had a question?
Yeah, I'm just kind of curious. I mean, whenever going overseas and doing these kinds of projects, I think the politics are like a really interesting factor because they can sometimes really change how you approach these. Some problems that come up that are unexpected. But you know, I'm just kind of curious about these method of clinics. You said about 700 of them were put up in China, and a lot of them were kind of done overnight. But do you have any sense in terms of the follow-up? Like, they might have 700 clinics, but do they have the money? Do they have the personnel? Do they have the support of the government to actually create a system where these maybe drug users are supported?
Right.
Do you have any kind of sense of that?
So it's pretty variable, as you can imagine. China is like a whole world in itself. I think it was a political impetus that created them in the first place. So, you know, for whatever reason, it was decided it was a good idea for public health reasons or whatever. And it's still, the legal system is what is sort of it's trying to catch up, basically, you know, because a police officer will have might do something different. A different police officer might do something different. They might send someone to a work camp as opposed to sending them to a treatment. And then in some rural areas, there are access issues. You know, there are mobile methadone clinics, but they have trouble getting to a lot of rural areas where IV, you know, drug use is very prevalent. So yeah, another thing for me to explore when I'm out there.
I had a question about where the data is coming from. Maybe you've already explained it. Is it coming from the big entity, like the ministry of whatever, the CDC itself, or are you going to have access to maybe some clinic data? I mean, it's all de-identified, right, but like directly from the clinic. Because my experience in Zimbabwe has been that what the ministry gives you and what the clinic gives you is very different.
Interesting.
Yeah.
Well, so I have a lot of mentors. So my mentor in China, who is at Sun Yat-sen University, she's the director of the Center for Migrant Health Policy, and also the person who's doing a lot of research on this data. So her team has already kind of gathered this information, whether it's from the ministry or from individual clinics, and kind of organized it in the way that they do their research on it. So I'm using that data as opposed to going to the primary data. And they update that regularly. So like they'll say like between 2005 and 2010, you know, this is the prevalence of Hep C in our population. And then, you know, as time goes on, they'll add more information. Yeah, so I'm lucky that I was able to design my research around something that already exists sort of in the university setting. Yeah.
It's Mandarin speak for China, or is that
Oh.
Chinese?
Cantonese. So it's Cantonese and Mandarin. Supposedly you can get by if you know one or the other.
Do you?
I can speak both, but hopefully I'll learn more. Yeah.
Questions for Chris?
Sorry, one other question. You may have said this, and I may have missed it. Besides going to these methadone clinics and sort of using that as an avenue to work on, you know, their follow-up for their HCV as well, how else do people typically follow up on their HCV?
So, yeah, that's a really good question. So, there isn't really anything set up right now. So the way HIV works is you get referred for treatment. So your treatment's not managed in a methadone clinic. You get referred somewhere where they'll take like the idea is that you also, you know, there's some models in Australia, you want to link people to care. That's basically what it is. And there have been some studies really, really awesome about Hep C treatment actually being administered in a methadone clinic setting. Like literally, you have a provider that's comfortable with doing it in methadone clinic and says, you know, if you have Hep C, let's check out what your liver looks like, let's give you some medications. But that's like in Australia, and I haven't seen that replicated anywhere else. And there are other issues with that. You know, there's sort of disclosure issues. Sometimes, you know, people in methadone clinic kind of want to keep that separate from the actual provision of certain health services, because it's sort of like, well, if you're going to provide Hep C treatment, why don't you also provide, you know, hypertension and cholesterol, blah, 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 you know, all these things. So it'll be interesting for when I'm out there to figure out what that balance is and where they draw that line, you know, because, yeah, I mean, I feel like for Hep C, there's a strong argument for really providing care in methadone, but that's my perspective, and I don't know if other people feel the same way.
I'm just wondering sort of what the dropout rate would be among methadone users who are HCV negative, you know, and it's a different question, I know, but I think it'd be interesting to think about in relation to your project to see if there's significant difference.
I mean, yeah. I mean, the great thing about this design is it's pretty modifiable. You know, the data's there, so you can definitely go back and look at this question.
You can do a random sampling of
Yeah.
the population, just for you know, hypothesis generating.
Yeah.
The trouble with thinking about Hep C treatment is that it's going to change so dramatically within a couple of years. So the new drugs are going to totally replace interferon. Probably a main reason that you wouldn't want to do it in a methadone clinic typically is that it's pretty cumbersome and tricky to manage as a treatment, whereas the new treatments look like they're a lot easier. So I'd be a little bit afraid of looking too hard at that because it's by the time you get around to publishing it, it's, you know, it's
How soon do you think those new treatments will make their way down to?
First, maybe by the end of this year.
Even to like these remote?
Well, it's hard with China to say though, because, you know,
You
they
never
can
know.
decide at a national level that they're just gonna do it.
That's how they do it.
They
Like everyone.
They didn't have viral loads for HIV at all when they decided at a national level, and you just did it.
Thank you very much, Chris.